Thank you so much for having me. We've had some excellent clinical and surgical talks. Mine is on a slightly different tangent. So refractive surgery now, in most cases, you get the ideal outcome. But as we know it, you can't always do it. So how do we prepare ourselves for it, and how do we protect ourselves when that does happen? So it's important to have a thorough preoperative evaluation, set the right expectations, and then manage those unhappy patients. So starting with the thorough preoperative evaluation, there is obviously the green flags and the red flags that we're all aware about, and none of us would, operate any of those red flags. But there are some gray line areas. There is a survey which talks about how many ophthalmologists are willing to get refractive surgery, and the results are a little surprising. I mean, not many people want even laser refractive surgery, and a majority of ophthalmologists don't want lenticular refractive surgery on them. And again, a majority would definitely not get femtosecond laser assisted cataract surgery on themselves. So this is the survey. So then we also need to be aware when not to offer the surgery to our patients. Of course, thin corneas, suspect topographies here. You see you have a thin cornea, but also these changes coming up in bad D maps. You would definitely not operate on this patient. Also, sometimes we can ignore this and sometimes we do forget, but it's very important not to flatten the cornea too much, because then the patient is going to be unhappy with the visual outcomes, because there is a considerable amount of spherical aberrations induced if you either flatten the cornea too much or steepen the cornea. So sometimes good pachymetry but flat corneas, you have to say no for that reason. Extremely important to ensure refractive stability. If you have any doubt, especially in a younger patient between 18, 19, 20, be sure that there is stability. Wait for some time and then operate, because you might be in a hurry, but then you have to face that patient forever once, if there is progression that happens. Uncontrolled allergic eye disease is again an absolute contraindication. These patients are at a much higher risk to develop DLK later on, especially patients who have atopy. Again, significant dry eye, anterior blepharitis, posterior blepharitis, look for these. Do a Schirmer's in every patient preoperatively. Corneal dystrophies are often ignored as well. Sometimes we miss out, faint epithelial basement membrane dystrophy cases. So in that, obviously, you can do a PRK, but you should not be doing a LASIK. Even Fuchs. Another major cause of, post-operative complaints is because of patients having a large mesopic pupil size. So studies have shown that this is not really considered an absolute contraindication now if somebody has a large pupil size, but you must counsel that patient. You must tell them that they are likely to have glares and halos for much longer. And if you can, if the pachymetry does permit, of course, increase the optical zone as well. Uncontrolled diabetics, again, is an absolute contraindication. Somebody with Sjogren's, completely avoid, because these patients are likely to have severe ocular surface issues later on. Other autoimmune conditions where there are no ocular manifestations or they are well controlled, you can proceed. Now, it's very important to set the right expectations. We all have patients who want guarantee, who have absolutely unreasonable expectations, and you do at the end of the day have a machine. You do need an ROI to a certain extent, but you have to be careful there, because the mental discomfort that you get from these patients post-operatively, in spite of giving out the best outcomes, is probably not worth it. So try and avoid patients with absolutely unreasonable demands. Of course, counsel them well, and if they continue to have unreasonable demands or unrealistic expectations, it's best to avoid them. Then how do you manage these unhappy patients? So the most common complaints that patients have include blurred distance, blurred near vision, symptoms of dry eye, glares, halos, and night vision problems. And the most common complications you see is overcorrection happening, some amount of irregular astigmatism, dryness, regression, etc. And I will not go into the specifics of how you manage these conditions. This is something we all know of. But what is very well known and what has been found is that a majority of medical negligence claims that happen in refractive surgery are because of issues of consent. So it was only in 29% of claims where it was because of surgery being done where it was contraindicated. And though it was documented that most of the issues were not absolute contraindications and surgeries were done, there was still not enough evidence to show that patient had been alerted well enough about the fact that this is a gray area or this is a relative contraindication where the surgery is being done. So counsel well, and extremely important to document that well as well. We also are having people taking video consents these days. So especially in these gray areas where you feel that there might be issues later on, do a very thorough documentation. So thank you, and thank you so much for having me.
Excellent presentation, Dr. Tushar. My question is, so nowadays, as you said, you are taking these video consents. So are the patients being informed for the same? That we are taking
video consent we don't take in all the cases, but very specific cases where you are not sure of the post-op, and that is more often in cataract surgeries or complicated corneal surgeries. But even in refractive surgeries where you suspect there might be trouble, and you are sometimes not very forward with the patient. You're not sometimes you are not pushing for the surgery, but the patient is. So somebody who has, say, myopic macular degeneration, high myop, and the best corrected visual acuity is 612. You're planning a phakic IOL. You have explained to the patient that you don't expect too much, but you have to document that as well. So try and get that on a video consent.
Yeah. What we do at our clinic, that we have made the stamps. Suppose that there is a stamp, the patient is been explained the vision is less than 6.6. Patient is explained for the regression, and we have on our own language. I am from Gujarat, so we have in Gujarati, English, and Hindi as well.
Yeah.
So we make a stamp. We ask him and his relative to sign over that. That is one thing we are doing, which we can easily make those stamps, and we can be on a safer side, because as you rightly said, when it comes to the legal cases, all these consents plays a huge role. So generalized consent doesn't work. It has to be, you have to mention the specific complication which can happen to this specific case. So that is the way to go forward. And what would you do? Suppose you have a previous history of patient having a viral infection and the eye is quiet for absolutely about 5 years. Would you be like to operate on those patients?
Yeah, so previous viral keratitis, etc., you do have to tell the patient very strongly again that you can always have a recurrence. So, and plus any form of laser correction can actually cause a recurrence as well. So
yes.
it is, again, I think, not an absolute contraindication if it has been stable and there has been no recurrence for many years, but there is always the possibility. So again, I think it's the issue of the patient being well aware of what he's getting himself into.
Yeah, because we operated on a patient like this, and patient ended up having the recurrence, and it was so bad. We somehow were able to manage it, but the patient's base corrected visual acuity was reduced to 612. But that is the only case which has happened once in a blue moon.
Yeah.
And I think on those cases, you also have, as Dr. Tushar mentioned, the consent plays a huge